Well, good evening, everybody, and welcome to week 4 of the 21st annual Mini Medical School program. Again, my name is Dr. Richard Colgan, and I'm a professor of family and community medicine at the University of Maryland School of Medicine. I'm also vice chairman in our Department of Family and Community Medicine and executive director of the Mini Medical School program. We hope you enjoyed last week's session with Dr. Justin Price, who presented on chronic pain management, and Dr. Emerson Wickwire, who shared information on the different sleep stages and how to improve your sleep quality. A special welcome to those of you who are joining us for the first time this week. This evening, you'll be hearing from 2 of our esteemed faculty members, actually more than 2 of our esteemed faculty members, about 4 of our esteemed faculty members. But before I introduce our speakers for the evening, Ms. Robinson will share a few housekeeping items and reminders. Ms. Robinson.
Thank you, Dr. Colgan. Again, welcome to week 4 of Mini Medical School. Let's quickly review a few housekeeping reminders and items. Everyone should have the link to the electronic course materials. In the week 4 folder, you will find the faculty bios for today's speakers, as well as today's course materials. We will be uploading faculty presentations weekly, so please make sure you check the folder each week. In addition, kindly remember to complete the individual course evaluations at the end of each presentation. I will insert today's survey link in the chat box during our brief intermission. Please use today's link to evaluate today's presentation. And then also regarding attendance, please remember that graduation certificates of completion will be given only to students who attend 4 out of the 5 classes. Please remember to log in each week. We only know you're here if you sign in with the email address you registered with in Zoom. Moving on, questions. Please note that we will be taking questions at the end of the discussion. Our presenters will spend the last 5 to 10 minutes of their sessions taking questions. This definitely applies to our first speaker's presentation. Our second presentation will be a little bit of a different format. It'll be a panel discussion. So we'll explain how you can engage and interact during that conversation. Okay, so please make sure that you're inserting your questions in the chat box while the presentation is in session, or if you prefer, you can ask your questions audibly. Please raise your hand and I will unmute you, or you can use one of these 3 methods: by phone, by computer, or by using your Zoom app on your tablet or phone. All right, well, thank you for your attention. And now Dr. Colgan will introduce our first speaker for the evening.
Thank you, Lauren. It's my great pleasure to introduce Dr. Jenny Law. Dr. Law is an associate professor in the Division of Hematology Oncology at the School of Medicine. She completed her medical school and internal medicine residency training at the University of Maryland. She went on to complete fellowship training at University of Texas Southwestern Medical Center in Dallas, Texas. Her clinical interests include sickle cell disease as well as malignant hematology, including lymphoma. In addition to her clinical activities, Dr. Law is the fellowship director for the Hematology Oncology Fellowship Program. That means she trains all of the internal medicine doctors who want to grow up and become oncology cancer doctors and blood specialists like Dr. Law. So we're here to present on blood disorders, Dr. Jenny Law.
Great, thank you for that wonderful introduction. Let me share my screen. So today I'm very happy to talk about just the very basics of sickle cell disease. So like Dr. Colgan mentioned, I've been at University of Maryland School of Medicine on and off for 10 plus years. I'm an adult hematologist oncologist, and I focus on treating adult patients with blood disorders and blood cancers. So a few basic slides about, just what is blood. So that's the fluid that circulates in our arteries and veins. It acts as the body's transport system and plays a role in our body's defense against infection. It's about 8% of our total body mass. Blood is separated into 2 components. We have a cellular component and then a plasma or liquid component. So the cellular component is seen here. This is made up of red cells, white cells, and platelets. And then plasma is kind of the liquid component. It's a straw-colored liquid. Blood cells are suspended in plasma, and this is what carries water and nutrients to our various organs and tissues. So let's go through each one of these cellular components. So what do white cells do? So white cells fight infection. They account for 1% of your total blood volume. The most common white cell is the neutrophil, which is the body's first line against any sort of infection. Platelets are these very small cellular particles seen here. They help blood clots form at site of injury. So if we cut ourselves, this is what goes to that site or that cut and helps form a clot to stop bleeding. And then red cells are seen here. These are the most abundant cell in the body. They carry oxygen from the lungs to the rest of the body. And then they return carbon dioxide from tissues that have used up oxygen. They take that carbon dioxide back to the lungs to be exhaled. So many people ask, why is blood red? So that's due to the presence of hemoglobin. So hemoglobin is a protein which helps facilitate attachment of oxygen to our red blood cells and gives blood this bright red color. So arteries take blood away from the heart. So they carry oxygenated blood, which is this bright red color. And then veins carry deoxygenated blood, or blood where all the oxygen has been used up. They carry that back to the heart so that the heart can then recirculate, go through the lungs, and pick up more oxygen and send that back out to the body. So veins have this darker blood, dark red blood color, and then arteries will carry this bright red blood color. So where does blood come from? So blood is made in cellular, various parts of the body, but mainly produced in the bone marrow. So those red cells, white cells, and platelets that we talked about earlier are all made in our bone marrow. So in adults, the biggest site of bone marrow production are the long bones in your body. So specifically the bones where your hip is, as well as where your femur is. Red blood cells are produced in response to a hormone called erythropoietin. This is secreted by the kidneys. So this hormone is actually decreased in patients who have renal disease, especially patients who are on dialysis. And these patients often will have anemia, and they have to get exogenous replacement of erythropoietin given to them via injection every 2 weeks at their dialysis center. In general, red cells live for about 120 days in circulation. So the bone marrow is always turning over new red cells as well as white cells and platelets to replace the cells that are dying out naturally in circulation. So the rest of our talk will focus on red blood cells because that's where sickle cell anemia affects that cellular structure. So red blood cells lack a nucleus. This allows for increased flexibility of the cell as it has to traverse different capillaries, venules. It can easily change shapes and helps the red cell fit through even the smallest blood vessel within the body, but it limits the lifespan of the red cell. And again, the red cell only lives for about 120 days out in circulation. When we think of blood disorders, they can either be abnormalities in the size of the red cell or the structure of the red cell. So red blood cells, again, consist of hemoglobin. Hemoglobin is an oxygen-carrying protein. There are two main types of globin genes that make up adult hemoglobin. So there's the alpha globin gene seen here, and then the beta globin gene. So adult hemoglobin is 2 alpha globins that are paired with 2 beta globins, and then they pick up, each one of them picks up heme group, which helps with binding iron and attracting oxygen. This protein attaches itself to red blood cells and helps facilitate oxygen delivery throughout the body. So normal adult hemoglobin is represented as hemoglobin A. Again, it consists of 2 alpha globins and 2 beta globins. After birth, There are 3 acceptable types of hemoglobin. So hemoglobin A, or adult hemoglobin, which is seen in most individuals. There's a normally occurring variant called hemoglobin A2. And then there's something called fetal hemoglobin, which is where the gene that makes gamma globin, which is really present prior to birth, that gene is never turned off, and patients have persistence of this gamma globin production. And the combination of that plus alpha globin makes fetal hemoglobin. For most individuals, the gene that makes gamma globin is turned off at about 6 weeks, and the gene that makes beta globin starts to pick up, and that's where we have adult hemoglobin being made. So sickle cell disease is called a hemoglobinopathy, which means that there's an abnormality in hemoglobin. There are 2 main types of hemoglobinopathies. One is a quantitative type, where you're having structurally normal globin chains, but a decreased or imbalanced production of one or the other chain. So some people may be familiar with the condition thalassemia, which impacts either alpha or beta globin chains. So you're making too little of one and too many of the other. They're not balanced, and that causes red blood cell abnormalities. For sickle cell disease, this is actually a qualitative hemoglobin abnormality, which means that the abnormality is affecting how hemoglobin functions. So there's no problem with the number of alpha globins or beta globins that are being made, but there is a problem with how the beta globin is performing structurally. So sickle cell disease results from one single point mutation. So there's a mutation in the gene that makes beta globin. That results in what's called hemoglobin S, or sickled hemoglobin. This is a picture of a blood smear under the microscope, and you can see these characteristic sickled shapes, which is what gives the disease its name. So unlike our nice biconcave circular red cell, these pointy sickled shapes can get stuck in blood vessels and cause significant abnormalities. So this abnormal hemoglobin can cause this abnormally shaped red blood cell during periods of significant stress for the patient. Sickle cell disease affects about 100,000 individuals living in the United States. We have about 3,500 patients living with sickle cell in Maryland alone. And sickle cell trait affects about 8 to 9% of African Americans in the United States. There are 4 main genotypes for sickle cell. So the first is hemoglobin SS. All of them are inherited by autosomal recessive inheritance, which we'll go over in a few slides. Hemoglobin SS affects about 200,000 births worldwide. Again, results in a single amino acid substitution. So just one thing goes wrong, which causes this whole host of complications. And so you have one amino acid substitution here, and you have what is a water-loving amino acid called glutamic acid that becomes this water-phobic valine, and that causes some abnormalities and leads to that characteristic sickled shape. So in this schema, both mom and dad have sickle cell trait. And so this is just going over how people inherit sickle cell anemia. So in this schema, mom and dad both have sickle cell trait. They have a 25% chance of having a child who has no sickle cell trait and no sickle cell anemia. So the child inherits a normal A and a normal A from both mom and dad. They have a 50% chance of passing on sickle cell trait to their child. And then they have a 25% chance of having a child affected by sickle cell anemia. So that's where the child has inherited S from mom and S from dad. And 2 copies of the hemoglobin S give rise to the clinical manifestations associated with sickle cell disease. So that's why genetic counseling is certainly very important, especially if your partner has sickle cell trait and you are affected by sickle cell trait, in an effort to maybe anticipate what the risk is of having an affected child. Hemoglobin Sc disease is another form of sickle cell disease. This is the second most frequent inherited hemoglobinopathy. Affects about 50,000 births worldwide. In this, you're inheriting a copy of the sickle gene from one parent and then inheriting a copy of hemoglobin C from another. So hemoglobin C is a clinically asymptomatic finding, but again, it results from one mutation where you're substituting a water-loving amino acid, glutamic acid, to a slightly less soluble amino acid, lysine, on the beta globin gene. So this is co-inheritance of both the sickled hemoglobin and hemoglobin C. So in this scenario, one parent has sickle cell trait. Hopefully they are aware of their sickle cell status. And then another parent has hemoglobin C, and they really may not be aware of their status. This is not something that's checked routinely by newborn screening. And these patients are clinically asymptomatic without any sort of anemia. So without doing testing, they may not know that they carry hemoglobin C. In this scenario, they have a 25% chance of passing on the trait C, 25% chance of passing on the sickle trait, 25% chance of having a child with no trait who gets both A from mom and A from dad, and then a 25% chance of having a child who inherited S from one parent and C from the other parent, which is what would give rise to hemoglobin SC. And then finally, we have some patients who have what's called sickle beta thalassemia. So we talked very briefly about thalassemia, which is a quantitative hemoglobin abnormality. That's where you're making either no beta globin or very few beta globins in response to a mutation. So in these patients, they've inherited sickle trait from one parent and they've inherited beta thal from the other parent. So this can lead to either a complete absence of normal beta globin. That's where you have hemoglobin S beta 0 thalassemia. This can be very severe in terms of its manifestations. Or you could have a patient who has decreased synthesis of beta chains, which is represented as beta plus, which is a little bit less severe. These patients still make some normal adult hemoglobin. So this is much less common, but we do still see this in our patient population. So again, sickle cell anemia and sickle cell disease, these terms are really used interchangeably by clinicians, but to be very specific, the two most severe manifestations are people who have hemoglobin SS and S beta 0 thalassemia. We think individuals with SC and S beta plus may have a slightly milder clinical course, but they also can have very serious manifestations related to their disease. So many would ask, why has hemoglobin S, or this abnormal hemoglobin, persisted? So individuals who carry one copy of hemoglobin S, meaning they're heterozygote, they have protection against malaria. So over many generations, hemoglobin S has been selected for in malarial endemic regions. And that's why in general, sickle cell is more common in individuals of African, Middle Eastern, Mediterranean, Indian, and Hispanic descent. So it's found in geographic areas that were more prone to malaria. I think in the United States, we have the conception that sickle cell anemia is really a Black disease. And in the United States, the majority of our patients are African American, but internationally, sickle cell disease is not a Black disease. There are many different ethnicities that can have sickle cell disease. In Saudi Arabia, Yemen, and Southeast Asia, there are large populations of sickle cell patients. And even in my own practice in Baltimore, I've had patients who are Hispanic, of Southeast Asian descent, or even Mediterranean descent who have sickle cell anemia. So again, just to hone on this point, the persistence of this abnormal hemoglobin S, or sickled hemoglobin, really overlays nicely with the kind of malarial endemic region of the world. And that's why we still see persistence of sickled, this sickled allele that's passed down. A few slides just on sickle cell trait. So sickle cell trait is not sickle cell disease. About 8 to 9% of African Americans do have sickle cell trait. Most patients are asymptomatic, but again, just for the reasons that we saw earlier, a few slides, preconception genetic counseling is really essential. Really knowing your status and your partner's status is quite important in terms of predicting, what the risk to your offspring. People with sickle cell trait can have some specific complications related to their trait status. They can have an increased risk of kidney cancer at a younger age. They can actually have complications with exertion at high altitude. So there are some players who I think are since retired from the NFL who sustained splenic infarction, so a lack of oxygen to their spleen when they played NFL football at Denver, which is at a very high altitude. It stressed their body so much that they actually infarcted their spleen. They had severe left upper quadrant pain. So the NFL actually allows patients with sickle cell trait to sit out if they are playing at Denver. And then sickle cell trait is actually associated with increased risk of severe muscle breakdown with extreme physical stress. And a lot of that data comes from a very large study done of the military, which does allow individuals with sickle cell trait, but excludes them from certain roles within the armed forces because of this reason. So right now, newborn screening is done in all 50 states. That is not the norm outside of the United States. So every so often we will see patients who come from sub-Saharan Africa or India, where there is no newborn screening, and they're diagnosed with sickle cell disease at a very late for us at least, stage of their life. Patients who have sickle cell disease are followed with something called hemoglobin electrophoresis, which helps measure the patient's response to clinical interventions. And there is prenatal testing available. So if two parents want to know what is the likelihood of their child having inherited sickle cell disease, you can have amniocentesis or CBS done in advance of birth. So what happens to cause the clinical manifestations of sickle cell disease? So we think during periods of stress for the body, that abnormal amino acid, which doesn't like water, is exposed. This impacts the ability of the red blood cells to adjust or conform their shape, limiting the flexibility of red cells to travel through small blood vessels. The red cells then form that characteristic sickled shape, which occludes the blood vessel, and it prevents blood flow to tissues that need oxygen. So again, decreases the ability of the red cell to deliver oxygen to tissues that are in need, and that eventually leads to tissue death, which can be significantly painful and can also cause organ complications or toxicities. So again, the further you get away from the heart, the smaller and smaller your blood vessels become. So that's why this red blood cell shape is so important, because it can adjust to these very small, narrow passageways. But unfortunately, the sickled cells cannot do that. So they get stuck in these small blood vessels, and this impedes the flow of blood and impedes the delivery of oxygen to tissues that are in need. So let's talk about some of the clinical manifestations of sickle cell disease. So unfortunately, this is a disease that can result in decreased life expectancy. The good news is that our pediatric or young patients, there have been significant gains in their care. So more and more pediatric patients are reaching adulthood. But unfortunately, we have yet to see improvement in overall mortality or life expectancy for our adult patients. So those gains that we are making in pediatric care are really not yet translating to our adult patients. So right now, the median age of death for people with SS is about 42 for men, 48 for women. And for SC, which is slightly less clinically severe, the median age of death is still in the 60s for both men and women. So far below national averages for unaffected individuals. So our patients with sickle cell disease can suffer from significant anemia. So the normal red blood cell lifespan we talked about is 120 days. Unfortunately, patients with sickle cell disease, often their blood cells will only last for about 10 to 25 days in circulation. Majority of our patients will tolerate lower blood values. So a normal hemoglobin should be anywhere from maybe 12 to 15. Most of our patients live at like a 6 to 8 range on a regular basis and are able to, they've adjusted to that value. Many patients can have formation of Gall Stones due to chronic breakdown or hemolysis of their red cells. A lot of my patients have had gallbladder surgery to remove their gallbladder and remove gallstones. Patients, unfortunately, can receive blood unnecessarily. So if they go to a hospital that's not quite as familiar with the treatment of sickle cell disease, often many of the clinicians there will say, oh, your blood is low, you have to get blood. And they can just get transfusions when they don't need to get transfusions. And this can result in what's called iron overload, so too much blood. The iron in blood transfusions can build up in patients' liver and heart, which can damage their organs. And then patients can also be what's called alloimmunized. So if they're exposed to a lot of blood over their lifetime unnecessarily, they can develop antibodies to the blood, which can make it very hard to find matched blood when a patient does need a transfusion in an emergent situation. One of the scariest complications of sickle cell disease is something called acute chest syndrome. This is the leading cause of death for both pediatric and adult sickle cell patients. As you can see in the lungs, there are a lot of small blood vessels that feed the lung tissue. So when you have these characteristic sickled cells, they really get stuck in these small blood vessels, which can prevent, again, oxygen exchange or oxygen delivery. So patients will often present with decreased oxygen levels, significant shortness of breath, and fevers. And we treat these patients by either giving them simple blood transfusions, so 1 or 2 units of blood, or exchanging their entire blood volume in our ICU. One of the most common manifestations of sickle cell disease is something called vaso-occlusive pain crises. So these are severe pain that manifests in the joints, the long bones, the back, or the chest, and often requires hospital admission for IV pain medicine and IV fluids. The triggers for a pain crisis can vary from patient to patient. It includes dehydration, cold temperatures, or weather fluctuations like what we're experiencing right now, infections, stress, and exercise. Specifically, swimming is a very common trigger, and we think that's because of the transition from maybe a cold temperature in the water to the warmer ambient air. This is a picture, 2 pictures done by a patient who was living with sickle cell disease, just to depict what he felt like when he was in the midst of a crisis. And this patient actually passed away a couple weeks ago at the age of like 42 from complications related to sickle cell. I'd say the majority of our adult patients do develop chronic pain from underlying sickle cell disease. It can be really hard for our young adult patients, patients who are in their 20s or early 30s, to accept that pain is going to become a daily part of their life. As clinicians, we really don't have a great understanding of chronic pain in sickle cell. We think there could be some issue with how patients are perceiving pain after a lifetime of suffering, as well as probably some damage to the nerves. So probably 2 different types of pain are at play. Many patients are given pain medications, which includes narcotic pain medications, but we do think that patients' pain is often undertreated upon presenting to the hospital, and that may be because of provider biases against individuals with this disease. But besides the complications that we mentioned, there are a host of other complications from head to toe. So just really to underscore the severity of this condition, we've seen patients who have lung damage, kidney damage, issues with their spleen, problems with their eyes, and then problems cognitively because of prior strokes from sickle cell disease. This condition requires ongoing medical care, especially into adulthood. Many patients, unless they live at in a large urban setting or close to an academic center, do not have access to a blood doctor or blood specialist, and there really is a lack of sickle cell specialists nationally. So what are some treatments for sickle cell disease? So in 1995, the FDA approved hydroxyurea, which is an oral medication that increases the production of fetal hemoglobin. So several slides ago, we talked about fetal hemoglobin is usually turned off at 6 weeks of age, and adult hemoglobin takes over. So in this situation, this pill medication is stimulating the bone marrow to make fetal hemoglobin that had previously been turned off by the body. And we believe that will decrease the production of sickled hemoglobin. Other treatments include red blood cell exchange. So this is when the patient has what's called a metaport. And every month they come to the hospital and we remove about 6 or 7 units of blood at the same time as we are giving them 6 to 7 units of unaffected blood. So the goal is we're trying to maintain a lower level of sickled hemoglobin in the body. In 2017, the FDA approved a powder medication called L-glutamine that's taken twice a day to try to reduce the number of pain crises. And then in 2019, after a long gap of medication approval, there were 2 new medicines approved for sickle cell, which have really helped with, I think, symptom management. The first is called Chrysanthem. This is an IV medication given once a month as an outpatient, which has been shown to prevent pain crises. So I think this has been a very helpful medicine for a number of my patients. It's very well tolerated and has been shown to prevent crises and prevent the need to go into the hospital. The other medicine that was very impactful is an oral medication approved in 2019 as well, which helps raise hemoglobin. So this doesn't impact the pain manifestations of the disease, but we think by having a higher hemoglobin, this may prevent some of the long-term organ dysfunction that our patients suffer from. So just to recap some milestones in sickle cell disease, we have really understood how sickle cell affects red blood cells for some time. This again was first described in 1904. This was the first disease understood at a molecular level. In the 1950s, we discovered the mutation responsible for sickle cell disease. In 1972, the National Sickle Cell Anemia Control Act was signed into law. And in 1995, we had the approval of hydroxyurea. But really in the past 20 plus years, there has been a paucity of advancements in terms of the care of disease, especially the care of this condition, especially given the number of patients this affects nationally. So what are some barriers to development of new treatments for sickle cell disease? So one is lack of research funding. So for example, sickle cell disease affects 3 times as many patients in the United States as cystic fibrosis, but receives about 1/4 the amount of funding. There may be some racial discrepancies that underlie this. In the United States, sickle cell disease primarily affects African Americans. In contrast, cystic fibrosis affects probably 95% of individuals are Caucasian in the United States. So again, a significant mismatch in fund allocation, resource allocation for this condition. Much more advocacy is needed from non-governmental sources, and really advocacy needs to be sort of done at a national level. So in Maryland, we have the Maryland Sickle Cell Disease Association that works with the National Sickle Cell Disease Association of America. And there's kind of a lack of clinical trial participation. So in the United States, African Americans are most likely to have sickle cell disease, but unfortunately, for reasons that we will review, they are least likely to participate in clinical trials. So just to touch base about what is a clinical trial? So it takes about 12 years for a new medication to be developed. Only about 5 out of 5,000 drugs that enter preclinical testing ever progress to human testing. And only 1 of these 5 drugs tested in humans are ever approved. So clinical trials refer to 3 phases of study in which the safety of a new medication is tested over time. These phases can last for about 6 to 7 years prior to collecting data, which is then submitted to the FDA for review. That review can take up to 2 years prior to the FDA potentially approving a medication. So this is a nice quote from the CMO of Pfizer at the time, who talked about, what are some barriers to clinical trial participation? And they say, shamefully for us, some drugs have failed because we did not have enough participants in clinical trials, and the warriors, the heroes, are what's required in order to advance our treatments. We cannot do it ourselves. And that's really an issue that we continue to face in sickle cell research. So what are some barriers to clinical trial participation? So, unfortunately in this country, African Americans have a significant history of mistreatment by the medical community. There is longstanding and probably rightfully so fear regarding possible exploitation, which can lead to distrust of medical personnel and worries about lack of autonomy. There's also lack of awareness regarding clinical trials. We've seen that in some studies, African Americans are not offered clinical trials at the same rate as Caucasian participants. There is lack of access. So many of these trials are centered at large academic medical centers. So if you live in rural America, you may not have access to a large center. It may not be easy for you to travel to one. And often there are times when there's concern that participation in a clinical trial will mean that the patient is not receiving treatment. So unfortunately, two scars on clinical research exist in this country. One is the Tuskegee syphilis experiment, and the other is probably Henrietta Lacks. So Tuskegee syphilis experiment is where, in the 1930s, the US Public Health Service enrolled about 600 impoverished African-American men in rural Alabama. About 400 had previously contracted syphilis. They promised free medical care, meals, and burial insurance. And the purpose was to observe the natural history of syphilis. Participants were never told that they would not receive treatment for their syphilis. They were not told if they had the disease. And during this time, penicillin was developed as a cure for syphilis, and this was withheld and not given to participants, which is just abysmal. So there were a number of victims. Many men died of syphilis. 40 wives contracted syphilis, and 19 children were born with congenital syphilis. So unfortunately, this significantly damaged the trust of the African-American community toward public health efforts. Certainly, there's a reluctance that's been longstanding to pursue preventative care. We think that this may continue to impact lower life expectancy for Black males in this country, and has been cited as a longstanding rationale for the underrepresentation of minorities in clinical trials. So what's the legacy of Tuskegee syphilis experiment? In the 1979, there was something called the Belmont Report, which established the Office for Human Research Protections. This is what established institutional review boards, which protect human subjects. So right now, all studies require informed consent, communication of diagnosis, and accurate reporting of test results. And then especially familiar to our Baltimore City residents is the story of Henrietta Lacks. So this woman presented to Johns Hopkins in 1951 with a knot in her womb. She was diagnosed with cervical cancer. During treatment, 2 samples were taken from her cervix, but without her permission or knowledge. And this established a cell line, which has been used in biomedical and commercial research for several years. The NIH recently reached agreement with the family regarding control over the use of the genome, and this established a need for consent for tissue procurement and tissue banking, including how this tissue will be used for further research initiatives. So I would argue that the longstanding legacy from Tuskegee as well as Henrietta Lacks plays into probably the lack of enrollment we see in our clinical trials for patients with sickle cell disease, and this may underpin some of the challenges we've had with advancing care for these patients. And then it's important to just talk a little bit about lack of access. Here in Baltimore, we are very fortunate in that we are very close to many large academic centers. The majority of clinical trials are concentrated at large academic medical centers. So at Baltimore, right, we have Hopkins and Maryland. We are also very close to the National Institutes of Health in Bethesda, Maryland, located about 45 minutes south of us, and about an hour and a half north of us, we have University of Pennsylvania in Philadelphia. And so, when I speak to my patients, we talk about perceived discrimination, how that leads to distrust of healthcare providers, and how that ultimately is probably limiting clinical trial enrollment. And that's something that we as clinicians have to continue to work against and improve. So finally, we'll finish with some curative options for sickle cell disease. So the main curative option that's available right now is something called bone marrow transplant. This is when bone marrow is harvested from a donor, which is done in the operating room. The recipient receives chemotherapy to wipe out their immune system, and the donor cells are then transfused, just like a blood transfusion, into the patient. There's a period where the recipient has a very compromised immune system. They can be at increased risk for severe infections as they wait for the new cells to hone into their bone marrow and start making normal white cells, red cells, and platelets. When they do start that production, these red cells are going to be unaffected by sickle cell. Unfortunately, only about 10 to 14% of sickle cell patients have a matched sibling or an unrelated donor. As a result, many centers have pioneered what's called half or haplotransplants. So everyone who has a sibling, a parent, or a child has a half match available, and patients can even donate if they have sickle cell trait. So across town, this is really pioneered at Johns Hopkins, and then this is a very valid curative option for sickle cell disease. So I have a patient who went to Hopkins. She was in her mid-20s and has been cured of sickle cell for the past 3 years because she had a transplant from her mom. What are some investigational options? So one is gene therapy, first published in the New England Journal of Medicine in 2017. So this is where a virus is used to take the patient's own cells and correct the one mutation that causes sickle cell disease. So using a viral vector to fix that mutation, the patient then gets chemotherapy to help make some space for these new cells, and the patient's own cells are reinfused into treatment after treatment. So this is a really attractive option because it circumvents the problem with lack of donor availability. And very close to home, the NIH was a clinical site for this trial, which is active. So that means they're studying the results, but not recruiting new participants. And then more recently, there was a published report of something called CRISPR technology to edit out the genetic abnormality which causes sickle cell. So then this again is very attractive. This is where you have your abnormal sickled cell. Gene editing is applied to kind of eat out that abnormal substitution. Something, the normal one is replaced in there. These cells are then given back to the patient and they make healthy red blood cells as opposed to these sickled cells. So both gene therapy and gene editing may be on the horizon for our patients, although larger studies are going to be required. And these are still, very promising therapies for the future. If you or your patient, if you or family members or friends, suffer from sickle cell disease and are interested in clinical trials, this is the clearinghouse for all clinical trials in the United States. It's called clinicaltrials.gov. It's very easy to use this website. You just search for, sickle cell anemia, sickle cell disease, and it'll pull up all clinical trials that are open at this time, and one can sort of peruse what may be close to home or of interest. So again, patients can gain access to investigational medications that may not otherwise be available. Patients are certainly free to withdraw from clinical trials at any point, and many measures are in place to ensure patients are receiving standard of care. You do have an intensive clinical research team that's focused on your health while enrolled in a clinical trial. And for our patients, this can certainly be a meaningful way to give back to medical research and help others with sickle cell disease. For friends and families, we certainly encourage blood donation. So the American Red Cross is always in need of blood, specifically blood from underrepresented minorities, which are we do not often have enough of in the blood pool. And so this is a very easy way to give back and to support others. I certainly encourage everyone who's eligible to register to be a bone marrow donor. You can go to this website, bethematch.org. They accept individuals age 18 to 44, and they send you essentially a cheek swab, which you can do at home and then send back to register in their system. And then the Maryland Sickle Cell Disease Association is a great resource for patients and their family members if they want to get involved with more advocacy. So as we conclude, I want to impress upon everyone that a cure for sickle cell is available. Newer treatment options are also available, and we certainly encourage everyone to be evaluated at a large academic center just to at least have that expert consultation. I do think clinical trial participation is essential to move care forward for this disease, and advocacy, like with all conditions, is certainly very important. So happy to answer any questions that anyone may have about sickle cell clinical trial participation going forward.
Yes, Dr. Law, it looks like a question came in during your presentation from Ms. Skylar Payne. Skylar, feel free to unmute yourself if you'd like to ask.
Yes, my question was, what's the difference between sickle cell and lupus?
So lupus is an autoimmune condition, whereas sickle cell disease is a genetic, so something that has been inherited by the patient, a genetic abnormality in how our red blood cells are shaped. Whereas lupus is something that usually develops during a patient's lifetime, and we don't know the particular trigger, but it's not something that has been inherited by the patient.
Alrighty. Any more questions? You can feel free to unmute yourself or put them in the chat, but feel free to unmute.
Dr. Law, while people are thinking of questions, I don't know that so many of our local residents are aware of what a major institution the Greenbaum Cancer Center is, and the University of Maryland Medical Center's, hematology, oncology, cancer resources. Do you care to let folks know how great you and your institution are?
Yeah, we are certainly a large institution. We are one of the comprehensive cancer centers. So nationally, there are probably about 45 to 50 cancer centers that are recognized by the highest level designation by the National Cancer Institute. So both across town, Johns Hopkins, as well as University of Maryland Cancer Center, both have the highest level designation. And so we're certainly very active in clinical trials for a whole host of cancers. I do think there's a specific strength for both breast cancer, GI cancers, as well as blood cancers like leukemias and lymphomas at University of Maryland. And we work very closely with our colleagues across town at Johns Hopkins. I think in many diseases, we have a very collaborative relationship with them. They have a very large sickle cell program. I'd say we're about a moderate sized sickle cell program, and we work very closely with the doctors there as well to make sure we're providing uniform care across town.
Thank you.
Thank you, Dr. Law. It looks like we have another question that came in from Sandra. Her question is, can Caucasians also have sickle cell?
I think it is certainly possible. It really depends on one's, ethnic makeup. I would say I've seen patients from Central America, patients of Hispanic descent, patients of Southeast Asian descent who have gotten or who have sickle cell disease. And so I think it's really important for clinicians really to be aware that sickle cell disease is not necessarily just a Black disease because it helps provide a wide lens to consider the diagnosis when someone's presenting with something somewhat more unusual. So for example, I have a patient who was only diagnosed with sickle cell anemia when she was 19 years old. And this is after she had presented to ERs or emergency departments frequently while growing up with severe joint pain. And she was never, I don't think anyone in America ever considered this diagnosis because she was of Indian descent. She was born in India and immigrated to the United States at age 3. So she, did not have newborn screening when she was born, and then came to the US, had frequent joint pain, would go to the hospital and get admitted. And no one really thought to think, oh, maybe this could be sickle cell disease because so many clinicians really consider this diagnosis only to be in African Americans. So it's really important for doctors, nurses, and other healthcare providers to, cast a wide net when they're considering this diagnosis.
Thank you. It looks like we have another question that came in. I believe this question is from Ms. Butler. The question is, if a person wanted extensive blood work performed, would you recommend visiting one of the centers you talked about?
Certainly. Usually, I would say that evaluation can start with your primary care doctor. So people who are affected by sickle cell anemia, usually have slightly lower blood counts than what are normal, and some can have very low blood values. So starting with a conversation with your primary care doctor to say, do I have anemia? Is there anything abnormal with my blood test or the way in which my blood cells look under the microscope would be the first assessment. And then asking, could I have an evaluation by a hematologist if there's any concern? But primary care doctors can send off the initial testing for whether or not someone has sickle cell disease. The actual workup is not very complicated. It's really just a blood test that can be sent by anyone. In the United States, right at birth, we do newborn screening. That's that heel stick that babies get right when they're born. Usually pediatricians should be giving that information back to new parents about a month after newborn testing is done. And they can tell their child, they can tell the parent if their child is affected by sickle cell or if they carry sickle cell trait. But so many patients, are really unaware of their status just because there's a lot going on in the newborn period. And parents may or may not remember, or the pediatrician may not communicate that effectively. So we do see a lot of patients who come to us, later on in adulthood who want to know their status.
Thank you for that information. Just a follow-up question to that. You said like a month after a newborn is born, you get that information. What if you never received that information? How can you backtrack to get that information?
I think that's something actually I'm involved in a state level kind of sickle cell organization through the state of Maryland. And we're talking about that exact question, how we can better incorporate the release of newborn testing results to new parents, essentially. So I think if your child has aged out of pediatric care, it may be a little bit challenging. So either asking the pediatrician if they have that history, or asking for a sickle cell screen, which is a simple blood test that can be done by any doctor.
Thank you.
Is there any known patient born with sickle cell anemia and was cured?
Let's see. It may appear that Dr. Law is frozen. Maybe her connection. Give it a minute.
While we're waiting for Dr. Law to correct me, but I think one could argue that the patients who received a transplant of blood who have not had a flare-up in 3 years' time, they might potentially be viewed as cured.
Dr. Law is probably trying to get back in.
Yeah, right.
Yeah, I just think it failed on her connection.
But I'll also further just, expand that, this is something that people are born with and genetic, and such as, that makes it, cure being probably very difficult. But again, maybe the transfusions or transplants may be something that could change the future of this. As Dr. Law was mentioning with that CRISPR genetic repair mechanism that's going on. Are there other questions or other comments? We can still take them while we wait for Dr. Law.
It looks like one came in the chat, Dr. Colgan. A question from Sandra. If an aunt died of sickle cell years ago, does this mean it is in your gene pool? Does it skip generations and then show up later?
And Dr. Law just texted me. She got kicked out of Zoom. This happened earlier this week with you, Maryland Zoom. Okay, so she's been kicked out. I'm going to say thank you, Dr. Law. And we'll handle it from here. How's that?
Yeah.
We'll say goodnight on her behalf.
Yes. Well, I'm sure we all enjoyed Dr. Law's presentation. Very, very informative. I'm sure many of you were taking notes as I was of myself. So
to answer the question, if an aunt died of sickle cell disease, does this mean it's in your gene pool? I think what one could say is it could potentially be in your gene pool, right? I mean, we don't get 100% of the genes from our parents. Well, I suppose we get them. We get perhaps 50% from the mother and from the 50% from the father. But so you know, that's the problem with genetic diseases, is that they can get passed down from generation to generation. And you know, it depends. Some of these are called autosomal dominant, which means, you know, more likely than not that the child may get it. Others are known as recessive, which means you need two parents with the same bad gene to have a child who then in turn may have that genetic disorder. So it's kind of iffy, but it's kind of it's an analytic tool that genetic counselors do all the time. There are people out there called genetic counselors. And so if you have, for example, a close relative with breast cancer or ovarian cancer, you can meet with a genetic counselor. And for certain types of genetic diseases, they can kind of give you an idea of what is the likelihood or the possibility that you could have this very same thing. So great question. You know, so the answer is maybe. It is 6:55. Maybe do you want to close us out then for this first session, Ms. Robinson? And
it is.
Come back?
Yes, it is. Just so that we have time to break before the 7 o'clock session. So we're going to now take a quick break. Of course, we will come back at 7:05. So a great time to kind of stretch your legs, walk around, get some water, and we will want to be back on time to start our 7 o'clock p.m. panel discussion. All right, we'll see you in a few minutes. Thank you.
Welcome back, everybody. Now let's prepare to move into our panel discussion for the evening. We'll be discussing the important and relevant topics of health equity and social justice. Like many other medical institutions and healthcare systems, we've all learned to adjust to a new normal and quickly pivot through the pandemic. And while we continue to utilize our existing technologies, resources, and expertise to ward off infection rates in this country and offer more adults and children protection against the pandemic, we're also on the front lines against another invisible enemy, racial and ethnic disparities in healthcare. Today, we hope to hear from our esteemed faculty and have them provide insight on this ongoing conversation. Today, lastly, please feel free to put your questions in the chat box during the discussion or raise your hand if you request to be unmuted. We'll pause to take questions as we wish to make the discussion as engaging as possible. This is a little bit of a new venue for us this year, particularly with Zoom. It'll be a tiny bit challenging as we ask our speakers, our presenters to take questions that have been submitted in advance, but also we invite you to submit questions as we move along, and I'll be posing questions to our presenters who will allow us to have a kind of back and forth conversation. I'll begin by introducing Dr. Londette Jones. Dr. Jones is an assistant professor of epidemiology and public health and has over 15 years of basic laboratory research with a focus on mammary carcinogenesis and utilizing transgenic mouse models to identify genetic and environmental risk factors for breast cancer. Her research programs have broadened to work more collaboratively across scientific disciplines and engages community partners to diagnose complex health issues through their understanding of the interplay of biological, environmental, and social factors. Dr. Jones also serves as Deputy Director for the Program in Health Equity and Population Health. Welcome back, Dr. Jones. Our second panelist for this evening is Dr. Anik Forrester. Dr. Forrester is an assistant professor in the Department of Psychiatry. As Chief of Diversity, Equity, and Inclusion for the Department of Psychiatry, Dr. Forrester provides strategic vision and leadership for all the department's diversity and inclusion activities and oversees the development and implementation of key goals related to diversity, equity, and inclusion. She also serves as the director for the Consultation Liaison Psychiatry Fellowship at the University of Maryland School of Medicine. And finally, Dr. Maureen Black. Dr. Black is a professor in the Departments of Pediatrics and Department of Epidemiology and Public Health. As a pediatric psychologist, she focuses on programs and policies to promote child development and prevent health disparities associated with poverty, nutritional deficiencies, and lack of responsive caregiving and learning opportunities. She directs the interdisciplinary growth and nutrition clinic for children under 3 years of age with growth and or feeding problems and conducts research in Maryland and in low and middle income countries throughout the world related to promoting children's development. Dr. Black has made significant contributions to the intersection of child development and nutrition. She spearheaded advances in child development by co-authoring 3 series of papers on early child development published in The Lancet. Welcome back, Dr. Black. So let's begin. What I thought I would do, what we thought we would do, Ms. Robinson and I, was to elicit questions and present them to our panelists, maybe one at a time, but certainly invite all panelists to chime in and give their thoughts. And this is meant to be more of a conversation and not a lecture. So my first question goes to Dr. Jones. How have health disparities been highlighted during the COVID-19 pandemic, and how is the medical community working to address them?
Yes, wow, that's a great question. And thank you so much for inviting me back to be a part of this panel. I recognize that COVID-19 has really unearthed a lot of longstanding health disparities in many communities. And it's interesting because while these health disparities have been longstanding, I think it has been the pandemic that has triggered perhaps more of a universal acknowledgement across the board, not only within the communities themselves, but the persons working in academia and the hospitals. And so I recognize that really COVID has raised the attention and has perhaps invited to the table to think through solutions persons that may not have been in the health disparities research before, like myself and several of the persons on the panel. So I think this, while this is a very, traumatic time, it's also an opportunity for many of us to start to work together collectively to address health disparities in a way that doesn't just sort of lend to one-sidedness of, say, academia or maybe boots on the ground communities working in silos, but for all of us to start to work together and start to think through how can we, as an entire community, work to address health disparities in a way that's going to be comprehensive and context specific.
Thank you. Thanks, Dr. Jones. To Dr. Forrester, how are social determinants of health and health equity related?
So thank you also for having me tonight. I think it's important to start off with kind of describing what they are, because I think we're using terminology a lot of times that people may or may not sort of all be on the same page about. So social determinants of health really incorporate everything in our society that determines how healthy a person is. So where they live, where they work, do they have access to care, and all of these sort of different factors that play into that. And then health equity is just about, is a person or people across any structure in society able to be healthy, able to get the same level of care, not facing a disadvantage because of their socioeconomic status, where they live, their racial or ethnic background. And so the two things are very connected, because all of the things that in our society that determine how healthy you are lead to disparities, because we have sort of relegated different people in society to different sectors. Certain people live here, certain people have access to this type of education, certain people do or do not have access to doctors, and certain people don't do or do not have access to even healthy food or places to exercise. So our society is sort of stratified people based on a sort of a system of, monetary sort of worth and what you can have. And so that makes it so that people can't attain health equity. Everybody doesn't have the same opportunity to be healthy. And so that's something that we have to kind of think about.
It reminded me of a cartoon picture that maybe you all may remember from a couple of years ago, where you had different people standing on different size boxes, trying to look over a fence. Is that a good description of the problem of health equity, would you think?
Right. So yeah, so health equity is really about fixing the structures, all of the things that are in place that make the system unequal, rather than just saying, I'm going to give you equal access. We have to address all of the different factors that make the access unequal in the first place.
Thank you. To Dr. Black, what are some examples of the most common disparities seen in children, and how does the quality of their home environment, specifically in terms of such as caregiving and learning opportunities, impact their ability to thrive cognitively, socially, and psychologically?
Thank you very much. Thank you for the question, and thank you also for the invitation to join Dr. Robinson and Dr. Forrester. I'm delighted to be here. Yes, it's to have the opportunity to talk about health disparities and when they start. I mean, they start before children are born. And the way that we see health disparities really from the beginning are differences in birth weight. So that health disparities are how the environment and the structures in the environment then impact us. So they start impacting us, as I said, before we were born, probably before we were conceived. And that might sound like, oh, what can we do to prevent these things? Well, there's a lot that we can do, and that's some of what we're going to talk about tonight. How to prevent some of the disparities, how to get rid of some of the structural things that have interfered with the equity that we think all children should have the opportunities to develop, to be healthy, to learn, to contribute to society. So there are things we can do about it, and we can talk about some of those. You know, when we think about what the pandemic has done, or what COVID-19 has done, in many ways we all faced the same storm. So it hit all of us. It's not that it didn't hit people who were wealthy, or it hit people who had fewer resources in a different way. It hit all of us, but we were not in the same boat. We were not in the same ship. And that's where you really do start to see the disparities that have occurred, that there were people who lost their jobs or lost their income. And so the disparities increased tremendously. So what do we do about that? You asked me a question about children in homes and what can we do in families when we're faced with things like not having enough food. And that was real. That happened in Baltimore. You could certainly see it in our communities. You could see it in the lines, like for the Maryland Food Bank. So it absolutely happened. And one of the things that we did as a community is to try to make food more accessible through things like the Maryland Food Bank, through increasing the SNAP, that's the food stamp program, providing access through WIC. But those things are hard, and they certainly didn't reach everyone that needed to be reached. Food, if I talk a little bit more about food insecurity, it's very frightening to families. And food insecurity means you don't have enough food. So you can imagine if a family does not have enough food, not only is there not food, but the parents are anxious. If you don't have enough food, you're very anxious. And so the concern, the worry, the anxiety impacts children really just as much as the lack of food does. So it's really a double hit or a double whammy. So we try to provide the food through services. And what it tells us is that moving forward, we need to figure out how to prevent having food insecurity in the first place, how to have a more equitable system so that we eliminate the food insecurity. So we'll talk about some ways to do that as we go on.
Thank you, Dr. Black. We heard from our last speaker about a genetic disorder, sickle cell disease, and I'm just reminded of that saying. We heard about being born with sickle cell and how that can be very detrimental to your health. And it reminds me, with the topic that we're speaking about now, of that quote: "Your zip code is more important than your genetic code." Right. So maybe somebody is born with a genetic code for sickle cell disease, which is terrible. But perhaps as terrible is or another form of terrible is perhaps to be born in a certain zip code where you don't have the same resources and life expectancy as somebody from just a couple of zip codes away, right?
Absolutely. Absolutely. Right. It's not easy to change your zip code either. There are things, and maybe we can talk a little bit about things that you can change or things that you can do. I'll start a bit and then turn over to my colleagues. And what I'll start with is what families can do to help protect their children and help look after their children. And there are things that families can do that don't cost a lot of money, but have a huge impact. And those are things that are not high tech at all. What they are, and this is with young children, it's through play and learning at home and spending time with kids and telling stories with children and reading books with young children. The evidence is really very, very clear. We did a large study looking at children who had been born with low birth weight and somewhat under a cloud. And the children were then followed throughout their lives up until adulthood. And what we found is that those kids whose parents during the preschool years played with them and provided learning in their home. It's the kind of things that you might do in a childcare center, but you do at home. You make bath time being playing, and that you do the storytelling. Those families who did that, their children did better, had higher IQs, did better in school as adolescents than families who didn't, even though all of the families had low birth weight and multiple other issues early in life. So there are things that one can do at home that have a huge impact on kids. And the other thing is, they're fun. It's fun to play with kids and to make kids laugh, to tell stories to children. It makes a big impact. So I'll let my colleagues talk a little bit more.
Dr. Black, can I ask you, up to what age would you say it applies? You know, reading and playing with children. What are you concentrating on a certain age range there?
You know, I think it starts when kids are born, and I think it continues through adolescence.
Yeah.
The play differs. So when kids are little, then you're telling stories. You're saying, "Let me count your fingers. I'm going to wash those toes." So that kind of play you do.
Yeah.
As they get bigger, you also get bigger, and the play changes.
Mm-hmm.
So it continues on and on and on. And if you stay tuned in to what your child is doing, you'll know how to play with them.
Mm-hmm.
You'll know what things they like, whether it's throwing a ball back and forth during adolescence, or teasing them in a fun, in a pleasant, respectful manner. The neuroscience will show us that it works through brain development. So there's a neuroscience aspect to it, but it's throughout life.
Thank you. Do any of our other panelists have anything they would like to add to this conversation? No pressure.
Yeah, I mean, I think that I agree with the concept that there are active things that families can do to try to really mitigate some of the issues. But I think one of the larger issues at play is sort of the systematic levels of hardship that some families have to go through that make it difficult for them to conceive of the active things that they need to do. So thinking about like where somebody is born, do you have heat and running water in your house? Are you able to get your child to a pediatrician to be able to help coach you through that? Do you have enough access to food? And so there's larger issues that I think are outside of the family's control that we still as a society haven't fully dealt with yet, that really downstream then affect the family being able to be as active, especially if they're under-resourced.
You know, I absolutely agree with you. And, you know, when you think about what happens within a family, it's certainly impacted by the support that the family has and the family's ability to have the things that they want and need to have to take care of their child. And you mentioned the heat and having enough food and being safe and feeling that you're not going to be in the midst of violence when one goes outside. And absolutely, those are situations that families need in order to have the wherewithal and the energy and so on to play with their children. I think I remind us, or I talk about the play and learning because there are things that families can incorporate into, like when they're bathing their child or feeding their child. And I think that we need to remember that those interactions are important, and just as we need to remember that we need to ensure that families do have the security and the food and the wherewithal to look after themselves. So it's, you know, it sounds trite, but it's the neighbor responsibility that it takes a community and a neighborhood to raise children and to enable families to raise children.
Terrific. This question is for Dr. Jones. What are some ways healthcare administrators and providers can achieve equity in ways that encourage and support the diversity of their patient population?
Sure, great question. So I kind of wanted to start off with the definition of, I like the definition Robert Wood Johnson Foundation gives of health equity, and that it means that everyone has a fair and just opportunity to be as healthy as possible. And, you know, this requires moving obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs and fair pay, quality education, housing, et cetera. Safe environments in healthcare, and, you know, similar to what we were just talking about, that, you know, it's really meeting persons where they are. Now, in the context of, you know, hospital administrators and providers, you know, our healthcare systems are traditionally set up to care for, you know, patients in a way that may not broaden the scope of all of the quality education, the housing, the safe environments, but all of these things we recognize are factors in whether a person stays healthy or not. So what I've been noticing and starting to, you know, hear among many of my colleagues is that in addition to simply, you know, I guess looking at the biological factors that will dictate the treatment, but taking a broader scope of their, after, say, for example, their stay in the hospital, what kind of housing conditions are they going into? Really, like I said at the start, finding ways to treat the person holistically. And I think perhaps to be equitable in a way that supports the diversity of the patient population is that they're coming in, they may have an illness, and as, you know, Dr. Forrester talked about before, there's upstream and there's downstream effects. And so how do we look at patients more holistically to support them in ways that hopefully whatever they're being treated for today, that when they go home, their conditions might be met through other sources that will hopefully prevent them from coming back again. So really thinking health as more than just the absence of disease, but that it's a really complex adaptive system that we recognize, you know, as administrators, as providers, that there's a whole diverse set of things that I had mentioned in that earlier definition of health equity that's going to determine whether that patient stays healthy, hopefully stay out of the healthcare system for, you know, causes that are preventable.
Thank you. Thanks, Dr. Jones. By the way, Ms. Robinson put in the chat box the link to that photo that I was referencing from a couple of years ago that we saw it during one of our presentations. She know already that some of you have liked the photo as well. Thank you, Ms. Robinson. To Dr. Forrester, achieving health equity requires addressing social and structural barriers such as structural racism and poverty. These barriers have different effects on different groups of people. Can you comment on structural oppression and how it has contributed to the outcomes we've seen during and prior to the pandemic, specifically in racial and ethnic minority groups such as Blacks and Hispanics?
So I think also I want to talk about like what structural oppression means, because I think that's important for us to kind of understand. So really what has happened is that we have developed systems and practices in our society that transcend various different realms, from politics to healthcare to financial employment. And so what has happened is that the structures have set themselves up in such a way that whenever something happens that disparately affects one group over another, we blame the individual groups. And that's kind of what happened in COVID. So in the beginning, it was kind of like, well, people aren't being responsible for wearing masks and they're not maintaining the proper precautions. Then it was about vaccine hesitancy among certain groups and what those sorts of narratives propagated was the idea that people just didn't want to be healthy. People didn't want to take care of themselves in order to avoid the sort of devastating effects of COVID. But what it left out was sort of the understanding that there were people that really had no choice. There were people who had no access to protective equipment. There were people that had to work, our frontline workers that had to work and had to be in the public without really any equipment or any protection. And then also when it came to vaccines, we sort of don't realize how privileged we are in the United States that we had access to vaccines. And then when access to vaccines first came out, it was unequal in how it was rolled out. And there's a whole history of medical oppression, experimentation on people of color that may have made some people concerned about getting vaccines that people don't talk about. So it's the narrative that it's individual people's faults that they experience a negative health outcome, rather than really telling the total story about all of the different factors at play. And so COVID really demonstrated for us, again, and I appreciate Dr. Black's point that it affected everybody, but we weren't all in the same boat. And so the differences in where people were, again, are affected by the structures under which we operate. And so I think that specifically for racial and ethnic minorities, we were the hardest hit populations in terms of numbers of deaths of people from COVID. And people are living in situations where there's multiple people living in a family, not able to protect each other. And so you're spreading COVID amongst each other. But again, not taking into account the factors that get people there. So it's not a nuclear family type situation where you have 3-4 people living in a house, but maybe 10 or 12 people. So it really, we have to start talking about how did we get to this place? And what were the systems that were already sort of set up to make some populations of people more vulnerable when we had a global pandemic?
What can one individual person do to maybe address or recognize or maybe help make better structural oppression of the nature that you're speaking?
So I think that individual people at this stage are kind of learning about the connections. I think we are all at different places in terms of our learning and understanding about the connections, because we've all been conditioned to really have that individual focus. So now a lot of people are really understanding the connections, really seeing how one sort of structure and one system can really have these long downstream effects. And I think we have to sort of start to individually take responsibility for not only the way that we're speaking about it, but how we're engaging with the people that have been the most affected. And if we have any ability to affect some change within our realm of control, I think we should. And so I think a lot of times you can feel powerless because it's kind of like, well, how can I change a whole structure? But it really is a process of individual changes, and a lot of people really recognizing that this is a communal issue, that having systems that are inherently set up to disadvantage one group or over the other is a problem shared by all of us, and not just the people who are disadvantaged.
I would absolutely agree with that, on the first blush, it's very hard to think what an individual person can do. But I think what is happening is there's an increased awareness among all of us. And the awareness then makes you a little more careful about saying something that someone else may take offense to, that you may not have realized. So it makes you a little bit more tuned in to doing that. It also helps our children by talking about these kinds of issues and displaying ways that you interact or ways that things have not been fair. So I think that it comes one by one. It also comes with recognizing those structural changes. In that display that you talked about, I don't know if they had the third band. The first band was children were on the same size box and the little guy couldn't see. In the second band, children were on different size boxes and they could all see over the fence. In the third in the third box, there was no fence.
Oh, interesting. Yeah.
No fence.
Right. Interesting.
So
It's
what
very good.
happens
Yeah.
is, yes, so that illustrates the change in the structure. Why did we have a fence to begin with?
Excellent.
So, yes. So, it takes people then having the forethought to say, why do we have a fence? Why are we doing it this way? So it's hard one by one, but we have to think that everyone has a voice. It may not be very loud, but every voice counts.
Dr. Black, maybe you can answer or address the next question that is in the chat box. What
Okay.
effect does lack of food have on young children mentally?
It's a big question, and it's a very important question. So typically what happens when people are food insecure, when they do not have enough food, what they do is they substitute cheap food. And so that because that takes care of hunger, gets rid of hunger. So they will eat something, and obviously I'm not naming the product, but they'll eat something like noodles that fill them up so that you're not hungry. But the nutritional value in noodles, just basically noodles, is very low. So that means that children are not getting either the macronutrients or the micronutrients. They're not getting the vitamins and minerals that they need. And so especially young children, where all parts of them are developing, then they need these vitamins and minerals. So that's not good for their health, not good for their brain development. When the other thing that happens is if you eat those noodles and you're not getting, and it's not only noodles, I just use that as an example, then some of those foods do not have many nutrients, but it's easier then to gain weight. So you can have children who are not very healthy, but they're gaining weight. So then, oh, what's going on here? The child is growing. Well, they may be growing on this very cheap food that's not giving them the vitamins and minerals they need. So we see children on both sides. We see kids who are heavier, and we see kids who have not had enough food. Because when I said first thing families do is get something to fill you up. But the second thing, if they really do not have enough, then the child doesn't have enough food and they don't gain the weight that they need. And that is what we see globally. And we don't see so much of it here, although in our clinic we do, but we see this in in many countries where children don't gain enough weight, so then they're thin, and then their linear growth, then they don't go enough, their height, they become what we call stunted. So, and the consequences of that are disastrous, meaning that they then don't gain the cognitive skills that they need. They don't do well in school. They don't do well economically, et cetera, et cetera, et cetera. And what the evidence will show us, not surprisingly, it goes to the next generation. So food is it's a critical aspect to children's early development and development throughout.
Thank you. Dr. Jones, over the course of the COVID-19 pandemic, what have we learned about the health needs of our local community? In what ways have we expanded access to care?
Yes. Such a very important question. And I just wanted to go back to that theme that Dr. Black raised at the beginning about how we were all impacted by COVID-19, but our outcomes, our health outcomes are all not the same. And so one big thing that we learned is that we really have to use a multi-pronged approach when it comes to addressing the health needs of the community. And what that requires is it's it's not a one size fit all. And really, to our theme of health equity, it's really learning about the health needs of the community and going into the community, whether it's learning about attending a community association meeting, because I do recognize that we're learning that, again, one size doesn't fit all. And we really need to understand at the level of the community, but also the level of individuals as well. Another health need that we're learning, and this is through several of my colleagues, is that we also need to pay attention to the dimensions of age as well. So particularly for the elderly, I know in a lot of, again, my colleagues, we were finding that there were degrees of social isolation, particularly that maybe the person may not have the family support as others. And then of course, as COVID-19 and everything shuts down, that social isolation is exacerbated to a degree where, it's social distancing, we can't get out, that family that may have visited you are just not there. And so again, really understanding the diversity within your community, the age, the needs, and then recognizing that in order to, down the road, expand access to care, we have to think through how our persons are accessing care. For example, everything mostly shifted to telemedicine. I found that a lot of my, even my family members, my older family members who are not used to using the Zoom as I do so often, how do we make sure that that access to a doctor's appointment that can only be through virtual, how do we continue those? So considering ways of when things finally opened back up and we had persons that were now going to the hospital and setting appointments, I know for some who may not have their own transportation, they may rely on taxi access. And I don't know if, again, the level of comfort of persons moving around is the same. I know there's a lot of people that have reservations about now using public transportation. And so how do we think through making sure that the care of persons who depend on public access, but that now there's, the pandemic to be concerned about, how do we make sure that that access to the hospital, whether it's public transportation, whether it's virtual through telemedicine, how can we expand what we're currently doing to make sure that we meet the needs of the most vulnerable persons?
You brought up an interesting point that I would love to hear your thoughts. We don't have to spend much time on this, but we're talking about health equality and disparities and justice. And you mentioned, age and older folks. Do you think there's, how much ageism is there out there, and how prevalent is it? How important is it, ageism?
Ageism.
Maybe I just made that word up, but I think.
Yeah.
I guess I mean, a prejudice towards older people.
Yes.
Yeah. I'll also defer to my other panels if they want to add in. So I guess what you're asking is, are we?
Yes.
Okay, repeat the question again.
Well, how prevalent or real is ageism amidst these other topics we're talking about tonight? Health disparities, social justice, health inequality. I sometimes see some older patients in their 80s, maybe doddering and bent over, and maybe not speaking as fast or listening as well. And I sometimes sense that they could easily get the short end of the stick.
Oh, yes. think what I do recognize are for those who, back to the social connection, like for example, I have a son who's able to assist my mother-in-law, who can be able to use a phone or computer, but for those who don't have access or the means to, or not able to keep up to kind of the mainstream that we're creating with our Zooms, with our telemedicine, I kind of feel like the pace that we're doing with technology is creating a digital divide for some. I don't know, I see Dr. Black shaking her head.
No, I absolutely agree with that. And you know what? It's going to get worse. And the reason it's going to get worse is because we are a society that is getting older and older and older. This means us folks, and the technology is like lightning speed, and it is getting worse. I was going to make a comment about the telemedicine also. I coordinate a clinic for children who were not growing well. And so as we transitioned to telemedicine, that what happened is we would alternate visits, and being able to see the children in their home with their families was fabulous. It was wonderful because you could see interactions with families. They didn't have to come to see us. We could see other family members who were there. They could talk to us. We could talk to them. So I thought that I hope that insurance will continue to enable us at times to have telemedicine. Now, it certainly doesn't solve everything, and there are people who do not have the connections, and so it doesn't always work. But to have that as an option is, I think, an improvement, and will enhance the quality of some of the services that we're able to provide. In terms of the ageism, Dr. Colgan asked about it. I absolutely, that too often healthcare providers, and I'll include myself, do not have tolerance for people who do not speak English, you described the person who was a doddering. Yes, they don't have tolerance for that. And part of it is that healthcare providers are expected to move quickly, very quickly, because you're then seeing more people. So at times, I think it's helpful for us to learn to slow down and listen. And by slowing down and listening, we can provide better services.
I also want to point out, just to hit the ageism point, about some of the myths that came out about COVID when we were first sort of in the middle of this pandemic, about how kids couldn't be infected, how older people, some people would die anyway. They were already old and sick. Those are the people that were going to get it. So ageism is a real thing. And that was something that was echoed across different aspects of our society, even by the former president. So the idea of sort of not taking into account like how perceptions about age can affect the structures, again, how much resource we put into something, especially depending on our perception of the value and the worth of the individual, I think is critical to the conversation about COVID, because it was real and it played out.
Absolutely. Absolutely.
To Dr. Forrester, let me ask, what are some ways we can cultivate a more culturally aware environment in settings where medical training and direct patient care take place?
So I think that's a great question. So I am responsible for a lot of education. I teach medical students, residents, and fellows, and I'm responsible for running a fellowship training program. And one of the things that has sort of played out for us over the years, but really over the past year and a half, 2 years with the pandemic, is how unprepared doctors are to really talk about healthcare disparities, social determinants of health, and how underprepared doctors are to really integrate changes in their practices, and then the way that we're interacting with patients to be able to address these more directly. So one of the sort of solutions that we've come up with is to really start talking about it. So we have incorporated in the everyday education of all of the trainees that we work with on my clinical service, conversations about health equity. We have trainees identify when they're seeing disparities taking place acutely in the care, because we see patients in the hospital setting. So these are the people that are sick. These are the people that have a lot of needs, and there's a lot of other professionals that are interacting with them. And so what we have found is that by giving trainees language to talk about what they're seeing, and also really understanding that they have a different perspective too, I think that there's a wide shift because the older, more established physicians really didn't get trained on this. So we also sometimes have to do bidirectional learning and learn from our trainees. So it's talking about it, it is identifying it, calling it out, and again, relying not only on individuals, but the larger groups of us to really change some of our practices that are inherently biased and affect people in ways that have negative consequences for their health long term.
Yeah, and I'm happy to say this has even been incorporated and embedded in the medical school training from our first to fourth year students in our new Renaissance curriculum, where we're incorporating concepts of health disparities. And I'm also co-directing a social justice class that many of the students elect to take. And so there's really an intentional effort, as Dr. Forrester said, where perhaps in the past these conversations haven't been maybe discussed in the setting, but there's a really, really huge intentionality from our School of Medicine that I'm really excited about, to make sure that our students are growing into more holistic, culturally sensitive and aware doctors.
I would strongly agree with that, that there is a sensitivity and a recognition, and people will be called out if they behave in a way that is really not culturally or not socially appropriate. And again, sometimes people don't realize it, and so that pointing those things out can be really very helpful. You know, if I change the subject, I noticed in the chat that there was a question about stress and what stress does to children. I just wanted to
Yes, please do.
That.
Yes.
Yeah, and that what happens, I commented earlier, when families are food insecure, when families do not feel safe, when families feel that they don't have the resources to take care of their children, they become anxious. We would all become anxious, and that's understandable. Children understand, children can feel anxiety, and it makes children feel anxious as well. But what happens when very young children feel anxious, it basically, it disrupts their ability to mount a stress response. When any of us feel stressed, then there's a stress response that pushes us into action, and then it stops. The fight or flight then goes back to an equal state. But if you are exposed to stress and anxiety excessively or all the time, then you lose the ability to go back to that equilibrium. So yes, it increases children's likelihood of getting ill throughout their life. You know, if we want to prevent chronic illnesses, such as diabetes and cardiovascular disease and so on, we build healthy habits, not among 50-year-olds, but among 3-year-olds, among young kids. So we help them develop healthy habits of eating and sleeping and playing, and try and have them learn how to manage the stresses of daily life, but not excessive stresses, so they're in better physical and emotional shape to be able to handle the rest of life. So stress can have a very negative effect on young kids.
Well, I think in the interest of time, let me ask if any of our attendees, any of our participants on the call have any burning questions for our three panelists before we kind of wrap things up. We've had a lot of great questions back and forth, and we've had a lot of great questions in the chat.
Yeah, Dr. Colgan, it looks like we did have a question come in from Skylar Payne related to the COVID shot. She's wondering, what do the panelists think about the COVID vaccine for kids, and should we as parents be talking to our children about why they should be vaccinated?
I think that absolutely, because kids have experienced a pandemic. There are some kids that really don't even have any context before this pandemic. So absolutely, there should be conversation about having a vaccine. I think parents should try to get as much information as they can. They should talk to their pediatricians. I have a young son. It's something that is not just like something that you feel immediately comfortable about. However, I think that given sort of the extended nature of this pandemic, the fact that we're still seeing deaths from COVID, we're seeing there's a lot of sort of unanticipated consequences of even being exposed to COVID. I think it's a real discussion and conversation that parents need to be having with their physicians, but also with their kids, because the kids that have experienced this pandemic right along with us.
I would strongly agree with that as well, that you know, some of the testing for the children's vaccine happened at the University of Maryland. We should be very proud of the work that has been done here. It's been done by incredibly competent individuals. And so I think that we should have confidence in the development of the vaccine and our ability. We're very fortunate to be able to have the vaccine that we can protect our children. You know, children can handle a lot more information sometimes than we realize they can handle. But these are kids who are now between 5 and 11 who are having this vaccine, and they deserve a fair and honest explanation of the vaccine and why they're getting it.
And in fact, you all have heard from these researchers this season. You heard from Dr. Kathy Newsell, and last year, Dr. Wilbur Chen spoke to this group. Thank you so much, Dr. Black, Dr. Jones, and Dr. Forrester for your time this evening in taking these questions and leading us on this really interesting conversation. With that, I'll turn things over to Ms. Robinson.
Yes, Dr. Colgan, I'd like to second that. A special thank you to all of our presenters tonight, especially our panelists who stuck with us our last hour and took a lot of great questions from our audience members. Well, this concludes our fourth session of Mini Med School. Before we log off for the evening, I would like us to take a quick look at what's ahead for next week. Next week, we'll be joined together for our final session of Mini Med School for this year. I can't believe 5 weeks have almost come and gone, but we are looking at our last session on November the 16th. We'll be joined by Dr. Joseph Martinez, who'll be presenting on the new Renaissance curriculum. And then we'll hear from Dr. Michael Jablanover, who will give an enlightening presentation on navigating our healthcare system and feeling empowered to take charge of your own health. And finally, we'll conclude this year's program with a brief graduation ceremony. We'll be joined by two very special guests. One is Dr. Destiny Martin. Her photo isn't shown here, but she is a former Mini Med School grad, and she will be joining us for a few minutes next week. And then we'll also hear from our very own Dean, E. Albert Reese. One last reminder, if we could all remember to just complete our course evaluations or our presentation evaluations. I did place the link in the chat box during our break. As we close out, I'll be sure to repost that for anyone who wants to stay online for a little longer and grab that link. Feel free to do so. All right, well, we thank you all for your time this evening, and we look forward to seeing you next week. All right, have a great night. Thank you.
Good night.
Thank you.
Great. Good night.
Thank you.
Thank you.
Have a good evening, everyone.
Thank you.
Excuse me?
Yes, did we have a question?
Yes, will you still be posting the survey link in the chat?
I am. Yes, I just grabbed the link. I'm going to post it again. You should see it appear in 1 second.
Okay, thank you so much.
You're welcome. So that link was just sent. So you can feel free to complete that survey this tonight. It'll only take a minute or two. We greatly appreciate you taking time to do this because we really do rely on the feedback that is shared to prepare for the following year. And of course, we're always looking to cover topics that matter to you and also to just improve the presentation and to improve our process. So feel free to share your thoughts.